Good day, good evening, good morning, whatever time it may be for you. Welcome to this episode in the Fall Voice webinar series leading up to our virtual Fall Voice 2020. I hope you've registered. Hopefully it'll be a great meeting in these virtual times for that kind of activity. Our participants are growing on the call, so thank you again for joining us. Back in early April, we did our first COVID-related webinar where we really knew very little about kind of how things were going to shake out and what was going to happen and whatnot. And we did a good bit of guessing. And now here we are, 5 months in, and a lot's changed in the sense of what we know. A lot hasn't changed. And so we thought it would be a good idea just to have an update from terrific individuals and colleagues from across the US, all in a little bit different stages of what's going on in the pandemic, to talk about our experiences both on the laryngology side and on the speech-language pathology side in our outpatient practices. And so that's kind of what we're going to be focusing on today. There's not going to be any slides. We're doing a panel format, pretty much our heads up for this, having a conversation about how we're navigating the various elements. So without further ado, we're going to do a little introductions. I'm Michael Johns. I am on the faculty at the University of Southern California in otolaryngology and director of the USC Voice Center in Los Angeles. Amanda?
Hey, thank you. I'm Amanda Gillespie. I am the co-director of the Emory Voice Center in Atlanta, Georgia, and the director of speech pathology.
David?
Hi, everyone. I'm Dave Rosow. I'm the director of laryngology and voice at the University of Miami here in Florida.
Ronda?
Hello, ladies and gentlemen. I'm Ronda Alexander, and I direct the Texas Voice Performance Institute, housed at McGovern Medical School in Houston, Texas.
Aaron.
Hi there. My name is Aaron Johnson. I'm a researcher and speech-language pathologist at the New York University Voice Center.
All right, and Yael. All right, we can't hear Yael, but Yael is the laryngology fellow at USC, and she's going to be moderating Q&A. So as a point of order, we're using the Q&A feature to submit questions. Some questions were submitted previously. Thank you for all of those who did that. We're going to try to integrate answers to that in our conversation, and Yael is going to be in the background on Q&A and maybe chiming in, so you may hear her voice from time to time. So we look forward to this. We thought we'd start, since we've got good representation all over, we thought just very briefly about kind of where we are in our communities with the pandemic. So, here in Los Angeles, we had a busy spike in cases in April, and we saw declines in May and June, and then with the 4th of July weekend, we saw another sort of resurgence of cases, and then things have been kind of steady. We've had our ICUs have been busy, but not at full capacity, and our hospitalization rates have been steady, but not climbing. We haven't seen a lot of dramatic improvements, and it's definitely feeling like we're kind of in this for the long haul. Amanda, how's things in Georgia?
Yeah, it's actually pretty similar. I don't know if we had as much of a spike as you had in the early days, but when we shut everything down, especially in Atlanta, in early April, it seemed to kind of hold steady for a while. Numbers fell pretty low in terms of hospital admissions, and then likewise, that post 4th of July, we saw a pretty big spike again, really quickly, much faster than we did in the spring. And hospitals again were filling up. We have decreased a little bit in recent weeks, and not to where we were even, I think, before that spike in July, but it's at least no longer climbing. Although, universities here are back, and a lot of them are back in person, and there have been really huge cases being reported at a bunch of local universities, really all over the state, not just in Atlanta. So I feel a kind of collective sense of like breath holding right now, just waiting to see, are these just going to be cases but not hospitalizations? And so who knows, if we think that things like hospitalizations lag about 2 weeks behind new cases, I think we're in a wait and see. So
David,
not great.
what, a 12-hour drive south from Atlanta
Yeah.
to Miami? How's it going there?
Things are better here. It's certainly things were definitely pretty rough there for a while. We didn't have the early surge that they had in New York, but because there's a very strong New York-Miami connection, we definitely had a lot of people who either had COVID or subsequently developed it while they were here. We started to develop our surge before 4th of July. I would say it was in mid to late June. And the ICUs filled up pretty significantly to the point where we even had to have one of our interns pulled off of inpatient ENT to cover a COVID unit. But I think we kind of reached our capacity, but never exceeded it. And things have definitely been on a better downward trend. I think that there's been better mask adherence, but it's, Florida, and we are the home of #FloridaMan. So there's a lot of, there are a lot of people trying to do the right thing, and then there are a lot of people who don't try to do the right thing. So it's definitely, like you said, Amanda, there's a lot of breath holding. We have our students are back on campus as well. Our university is going ahead with football games with, a lowered attendance. So fingers crossed.
Mm-hmm.
Rhonda, traveling a little bit west. How are things in Houston?
We are nervous. I think we also were not a part of that first wave, but it pretty quickly flipped, whereby I'm a native New Yorker, and at the outset, I was afraid to go to New York, and now I am banned from New York, functionally. And so our governor did not order masks during physician encounters in enclosed spaces until April 27, and it went into effect on the 1st of May. And he didn't order a statewide indoor mask order for the whole state until the 2nd of July. So we're really only, 2 months into people just wearing any cloth in front of their face at all when they're in crowded spaces. And our current case positivity rate is around 10%, which is down from our peak. We do a 7-day rolling average because obviously there's a lot of noise in the data with the various backlogs and processing times. So our peak was around July 4th, and that was around 23%. And that was when I was having daily nervous breakdowns because 1 in 5 random people on the street were going to test positive if they, felt like they needed to be tested. So that's where Texas is, and we are still kind of, we're coming down. Our ICUs have capacity right now. We are getting our daily updates, but I work in a 600-bed hospital that right now has around, we have not for several months had more than between 5 to 7 adult negative pressure rooms available. And a children's hospital down the street from me functionally converted into an adult hospital during June, July. So we do it big in Texas, unfortunately.
And Aaron, you were in New York City, were leading us all out of the gun. Tell us where things are now for you.
Yeah, we like to be leaders in the field, but unfortunately that's not a claim to fame that we like in this case. But the good news is that we had that early spike. March 12th, I remember, was the last day that I was in the city. I live out in Jersey and commute in, and I spent several months out working from home while my laryngology colleagues, Milan Amin and Paul Kwok, were on the front lines doing trachs and treating patients in the hospital, and it was pretty bad. We converted a lot of rooms, a lot of parts of the hospital to COVID wings. But thankfully, for the past, I think about 2.5 months now, we've been pretty stable. I think it's around 500 new cases a day, which sounds bad for some places, but for New York City, when we were up around over 10,000 at the peak per day, those are good numbers. In the time it took us to get an IRB together to study some COVID patients, we now cannot recruit patients, because most people that are coming in with COVID are coming in for other situations, and then they get tested and discover they have COVID. So we don't see the kind of volume or any volume at the moment that we saw before. So that's the good news. I think, like you guys have stated, we're all sort of holding our breath for the potential second wave in the fall. We don't want people to become complacent as schools open up. We know I've got a son going to NYU who is his roommates had to move in 2 weeks in advance to quarantine before classes started. So the universities in the city are taking it very seriously, and hopefully people will continue to be vigilant.
So let's dig into how we're navigating this in our outpatient practices. So sticking with you, Aaron, tell us how it's going down. Feel free to speak for both on the speech path side and on the laryngology side. How's it working for like new referrals, but either to speech path or laryngology? How's that flow and process work?
Yeah, sure. So we are pretty much back to pre-COVID volumes. Our arrangement is that our patients will make an appointment at the Voice Center with one of the physicians. So new patients come in to see the physician, and then there's a speech pathologist who's working side by side with the laryngologist, and then evaluates, looks at the chart, looks at the complaints to see if the speech pathologist should see the patient, because sometimes there's conditions that are purely medical that don't require a speech pathologist. And so the speech pathologist does the initial evaluation of the behavioral aspect of voice. We do our acoustic measures. That has changed in the way we do that. We have a voice lab, but we're no longer using that. So our adjustment to try to contain patients and limit the number of rooms that patients go to, is we bring them directly to the physician exam room, which is where our stroboscopy unit is. And so the speech pathologist will see the patient there. So we purchased some additional equipment, some microphones and USB interfaces to hook up to our Pentax systems, so that we can do recordings directly onto the computer, the strobe unit, actually, the strobe computer. And then we do our analysis offline, and I wrote some scripts for Pratt. So we had been a Pentax house and had been doing everything with the ADSV, but we're now doing that offline with Pratt. So that's an adjustment. We're not doing any aerodynamic measures at the moment. I've been investigating how we can do that. The limitation is that the Pentax system needs a desktop computer because of the interface, and so we'd have to roll a whole extra tower in there into each room, and it wouldn't work with the room we have and patient flow. So I'm anxious actually to hear Amanda's situation, because I know Amanda has been doing aerodynamic with the PAS system. So
Yeah,
talk about that since we're on that.
Go ahead.
Do you want me to jump in on that one?
Yeah, that'd be great.
So we are doing almost the opposite a little bit that you are. So we are, likewise, we have a multidisciplinary clinic. So we're seeing patients with laryngologists and speech pathologists together. We do the initial history intake and the strobe all together in the exam room. So the patient comes from the waiting room to the room that has the strobe tower in it. And then at that point, we kind of make the decision that, okay, this is a patient where speech is going to be involved more in their care. So then we move them to our voice lab. And we previously had, we still physically have, 2 rooms that could serve as voice labs. One of them is pretty small, and the other one's a little bit bigger. So we're kind of defaulting to the bigger room just to be able to keep a little bit more distance between us and the patient. We've set up the room now so that the patient is actually kind of sitting in a corner facing the wall. And we are doing aerodynamics. So while we're in there, we're of course still wearing our full PPE, because we are having the patient, they've removed their mask. We're having them do, loud voice, high voice. We're in a relatively small room.
Yeah.
So we're using the Pentax phonatory aerodynamic system. We have them do about 60 seconds worth of tasks. And so it's a relatively long recording period, but we are actually getting some acoustic data from that. So we're really just getting DBSPL and FO. So we're not doing the ADSV acoustics that we used to do, because from a cleaning standpoint for the microphone, we couldn't really figure out a way to keep the microphone clean between patients where we felt like we actually weren't getting interference from whatever the barrier was that we were trying to put over the mic. So we are then the entire pass unit gets cleaned in between every patient. So you take the whole thing apart and it goes off into our sterile processing room, and there's a couple of steps that it goes through for cleaning, and then it actually dries and then gets put back into a little sterile bag, almost like how they package surgical instruments, and then that bag is delivered back into the room. So that's how we're doing our voice lab now. But if anybody else has ideas of, like, what are you guys doing with your microphones?
Well, yeah, so we had been using the headset mic. We don't do the headset mic now, right? We have like Mike has there in his, with the microphone, and the mic never comes in contact with the patient. So it stays, you know, a distance about a foot away from the patient. And we had been using some caps like for earphones, you know, disposable on that. But you know, my thought is that even if the patient is spewing COVID onto the microphone, the outside gets wiped down. If there's any, you know, virus within the mic capsule or something, that's never going to come in contact with the patient any more than the monitor that's in the room or the strobe equipment, or, you know, so we just kind of keep the same kind of surface cleansing protocol. We just have that other kind of mic. And we're in full PPE the whole time too. We have the patient take the mask down when they're doing their acoustic tasks. And so by full PPE, I mean an N95, face shield, the hair net thing, the gown, the whole 9 yards.
The gloves.
Gloves, yeah.
So before we move on, Amanda and Aaron, so new patients, are they coming straight into clinic, or do they have a stop on telecare beforehand?
We have a little bit of both, actually. So when before we were back in the office in June, we were doing everything through telehealth. And so we now have most new patients are coming directly into clinic, but we have actually continued to have some telemedicine clinics that are still physician and SLP staffed together. And so we're still doing a little bit of a triaging system for some patients. And so honestly, I think it's just an issue of when patients call to make the appointment, if they want to wait for an in-clinic appointment, or I think they can probably get into that telemedicine clinic a little bit faster. But so now we're kind of doing a hybrid.
So a bit of a hybrid and kind of patient directed more than.
We are doing a multidisciplinary cough clinic that is entirely over telemedicine, where we have speech pathology, laryngology, pulmonary, allergy, immunology, and GI all together seeing patients, and that's entirely over telemed, which is actually now one of the beauties of telemedicine, because as you can imagine, it's impossible to get 5 people to see a patient in a clinic room at the same time, but everybody can, you know, turn their computers on from wherever they are for that. So those patients are all seen for telemedicine, the kind of refractory chronic cough patients, because they're seen in that clinic.
Rhonda, how's it looking for you? New patient referral, how does it go down?
My office is under regular function. And so the way our schedule kind of works is complicated in that we have about 14 doctors sharing only 17 rooms. And so we have a fair amount of rigidity about when you can be in the office in terms of like literally just sharing that resource fairly. And so we implemented telemed, I would say, later than we as physicians would have liked, and that had to do a lot with the university's infrastructure not really being ready to deploy the available technology that would let us do telemed securely and safely. There was a couple of weeks of doing telephone visits, and then, you know, right now, you know, today I had a half day and we just saw them full speed. A new patient, unless they specifically request telemedicine, just comes into the office at this time.
Got it. So most new patients coming straight into the clinic, and then some occasional telemedicine mixed in.
And they are very typically elder and or at a distance. Houston is kind of in a basin where, I mean, patients come from as far as 3 hours away to see us. And so some of them have been taking advantage of the telemed.
David, what's it look like? New patients.
I'm in a similar situation with Rhonda that I'd say that things have mostly resumed our normal operations. We went to total lockdown between mid-March and about mid-May. And so we were doing telemedicine visits. I found those, at least as a physician, to be very unsatisfactory. because I really wasn't able to make diagnoses. And in fact, when some of those patients did subsequently follow up for stroboscopy, they were found to have pretty significant pathology. So it kind of sort of emphasized to me that process doesn't really work for my evaluations. But we're back to doing our multidisciplinary clinic. I'd say that the only ways that we've really scaled back, we're not having quite the volume of patients that we had before in terms of having sort of an overbooked schedule. But we're still having patients do their acoustics in a separate room. They come into another room to do stroboscopy. That's done. We wear an N95 and a face shield. I don't wear a gown or a hairnet or booties or anything like that. There's been pretty good, literature showing that the spread is really aerosols and droplets. It's not so much from the fomites. So I mean, we still take every precaution with wiping down surfaces, but I certainly don't have the same level of concern that I'm going to get, that there's going to be spread from that route as I am with aerosols.
Oh, can I just add one more thing? Full on agree, David. We wipe down in between, but also because initially there was that concern for let the particles rain down for 20 minutes before you even do the wipe. We installed in each of our clinical rooms an air exchanger that reduced our wait time before you could kind of go in there and do your cleanup from 20 minutes down to about 5 minutes. So that really helped us be able to actually get patients in safely.
Yeah, I should say we did the same. We had a 60-minute turnover initially when they came through and looked at how fast our rooms turned over. So obviously, yes, based on your facial expression was our facial expression. So we got the air exchange now down to just 15 minutes. So that worked. I mean, it's basically like from 15 minutes from when you stop scoping till when the room can be wiped down and the next person come in. That's your normal counseling review recommendation time anyway, so it doesn't feel like a burden now.
I think it's an interesting thing that we have to consider, though, is like to what degree was your volume reduced by some of these changes, and I think that's the burden that we struggle with, is that we're trying to see patients. There was a huge buildup of clinical need during the real lockdown portion of the quarantine, but also, I mean, I'm sure all of us, our universities or our facilities really suffered financially. And there's definitely I don't know if incentive is the right word, but we're being pushed to do what we can to try to bring in clinical revenue so that people can keep their jobs and things don't go under. And so how do you balance that? Because I can tell you my volumes are probably down maybe, 20%, from my normal, which is not bad. I mean, again, it's back to mostly normal, but it's still, it's definitely reduced compared to what it was, in February.
Yeah, Aaron, go ahead. Sorry.
At USC, we're in a little bit of a similar situation to an extent as Ronda. We've had some limitations on just room availability and access because we've had some satellites which have not yet been fully put back up to speed, and with some social distancing concerns in the waiting area. And then our room cycle times, we are probably down about 30% in terms of our capacity to see patients in clinic. And we've then have infilled telecare in between. Our new patients who call to schedule we're seeing them all via telecare to start, largely related to the some of our room restrictions, and we need to preserve those spots for kind of known endoscopies. We aren't testing for any routine COVID testings. I know this came up in the Q&A. We aren't testing for COVID in any of our routine patient visits, unless it's it's a known aerosol generating procedure, which for us is any sort of mucosal traversing procedure. So injection augmentation, airway scopes, anytime we're using a needle into the mucosa, that goes for nasal debridements too. So we are COVID testing those, and we use a subset of our rooms, which we have HEPA filters in, and for those particular procedures. So most patients are coming in through telecare for a screen. We have an escalation protocol for airway and obviously emergency things to rapidly get those folks in place. But for us, it's a bit about room utilization for that, and so that's why we've kind of kept up on telecare. But since there was a question about COVID testing, let's go around the horn and who are you testing and who are you not? Rhonda, do you want to start?
Nobody. So basically what happens is, our office is a part of the university practice, and there are constrictions about what we can do that are not in the university practices protocol. So the university practice protocol, it was screening questions and a parenthetically often poorly executed temperature screen, whereby for several weeks I was 93 degrees. And so if you are not febrile and you are not actively coughing and you do not look like a zombie, you got in. And it was terrifying for a little while. But I literally actually had a patient get roomed, check his phone while the resident and I were preparing to come in. And when the resident went in, he said, "I need to tell you, I'm COVID positive." And we were like, "Okay, thank you. We appreciate you being, caring about us and sharing that. We will be back." And I basically wiped him down with one of those non-baby wipes, because I was like, "Oh my God, I need you to live for 3 more years. This is exhausting. You got to finish the residency." But yeah, down here, you pretty well had to be symptomatic to get tested. Now you can go to one of the county sites, but your turnaround time on that might be as much as 4 weeks, like the patient who is still waiting for his test from early July that I saw today.
David?
Same exact thing. I initially wanted to be able to test patients who are going to have procedures like, laser ablation, things like that, injections. Just was not feasible at all. Same problem, finding a reliable testing site where a patient could get tested and we could get the result back in, within 24 or even 48 hours was just, we're doing them for surgical testing, obviously for pre-op cases, but nothing for any of the ambulatory or office patients at all. They're just getting the same kind of question screening. There's definitely layers of security people have to go through. And, as you mentioned, we've definitely cut back on the number of, there's no family members come in, the waiting rooms are socially distanced, but there is just, we don't have the ability to do the level of testing, I think, for people who are getting office procedures.
Amanda, what's happening at Emory?
Yeah, so in the office, if you're just coming in for a regular in-office patient visit, it's a similar thing, like somebody takes your temperature at the door and asks if you think you have COVID. And if you say no, then you come in the office. But for all surgeries, procedures, they are getting tested 48 hours in advance, I believe, and then told, please basically self-quarantine for those 48 hours. And then they come in for their procedures or for their surgeries.
Aaron?
Yeah, we're in a very similar situation. No testing for outpatient visits. It's just questionnaire scanned for temperature at the door. But for any surgery patients, they do get testing. Testing is fairly widely available in New York City. I got my own test at a drive-through CVS. I did my own swab and before I returned to work. So we're lucky that we have the tests available, and the turnaround is usually a couple of days if you're just doing kind of a standard test. We do have rapid testing available on campus, obviously, if there's an urgent situation, but they discourage us from using it except for a really kind of dire situation.
And how about therapy patients? If you're going to spend an hour with a patient in your therapy room, what's happening there?
Yeah, so we don't. All of our therapy is completely virtual. And I just found out recently our reimbursement is actually the same for the virtual visits, which was a pleasant surprise. So as long as it's paid for, we're going to keep doing it virtually. There are some trade-offs. Obviously, audio quality is not as good. It helps if the patient is wearing a headset, even if it's just their Apple earbuds or phone earbuds, that's better than just going over the phone. And we have a setup in the office where we have a microphone and headphones. So we've made arrangements as best we can, but the audio quality still is not great. We actually were set up for telemedicine a year ago for SLP visits, for therapy visits. but had very few people take us up on it because it was all self-pay. So
Same,
now that
exactly the same.
it's reimbursed,
Us too.
people enjoy. Our no-show rates have improved tremendously. We can see more patients, so that's sort of one of the silver linings.
Now, that may not last. You're aware that the funding is. I don't know if you guys are lobbying as well, but that's something that we're definitely worried about.
For sure.
Well, and some things like Medicare still hasn't covered swallowing therapy, so that is definitely a problem. But for pretty much everything else, it's all telemedicine. We are offering a couple of in-person, in-clinic therapy slots a week. There are a few people who, if they really do not want telemedicine, we will do those for them. But, you know, we explain to them, like, you have to wear a mask and we have to wear a mask, and it's just a lot harder. So very, very, very few people want to do that. So we're like probably 99%, if not a little more than that, telemedicine for therapy. And it's great. And I will also say, as a little plug, it's great for quality of life for speech pathologists. It's really wonderful, especially as we're all, you know, so many people dealing with virtual learning, or, you know, Aaron, like you were saying, commuting in from home, like to cut out that commute because you have a whole day of telemedicine that you can do from your home office. I think it does a lot for morale. So for patients and for care providers, it's been nice.
So no one's doing routine therapy in person, pretty much all telecare.
Yep, all tele.
That's us too. Now we have a few exceptions, like patients that we really feel we need a hands-on therapy visit. Then we are COVID testing those, and we have been fortunate to have no problems with testing access, and so we certainly have been doing that sort of liberally. But interestingly, it sounds like I haven't heard of any outbreaks coming out of otolaryngology clinics.
I haven't either, and I think it definitely has to do with, we are pretty conscientious and sensitive to that early data that came out, that aerosolizing data. I remember I'm also like involved in the GME at our university, and I realized that I was getting data and information from my personal news sources like Twitter and things that I was reading that my institution was not aware of, because I had a level of heightened concern that they did not understand. And when I actually emailed them the data, I was like, why don't you know this already? They were like, oh, now we see why you're being so high strung and weird. I was like, yes, because my residents, right after the intensivist fellows, we are the next ones to die. And so they were like, oh, that's why you're being so hyped about all this stuff and, you know, switching to virtual consults for the hospital. But now that we have kind of concentrated, I think, that high severity of cases in hospital, the people who are positive, who are in the community, with the kind of the guardrails that we have up, the transmissibility is going down. I can see in our chat, Kay James has the same experience with me. The patients are coming. The patients are getting inpatient. They're getting face-to-face voice rehab in Houston. There is not a lot of infrastructure. There's a lot of private practices. There are a lot of hospital systems that did not invest in telehealth for speech language pathologists. And so if you are aligned with a system that did not invest in that infrastructure for you, you don't have a choice, unfortunately.
Yael, any questions? I know you popped in there for a second, so I figured that was a cue for some questions.
You maybe on the SLP conversation, somebody asked, what are the biggest challenges in virtual therapy, since most of you are doing fully virtual? For example, people that need more MTD hands-on therapy, or for elderly patients that can't hear. So more for the speech therapist, what are those challenges?
All right, let's switch gears. Let's talk about what's working in telecare and what's not working in telecare.
Aaron said before, the audio, we have created a little bit of a how-to. One of our speech pathologists, Diana Becker, made a nice how-to guide for the patient, how to maximize their audio for Zoom, which is the platform that we use. which is helpful because, you know, Zoom tries to be smart and tries to eliminate background noise. But if you're doing any sustained sound, Zoom will think that's background noise and just mute your voice. So we do that, but sometimes asking a patient to go into their audio settings on Zoom, that can take an entire session if they're not very technologically proficient. So I think the patient audio, you know, somebody today was doing their therapy parked in their car on the side of the road, and you could just hear the traffic, and the audio is the thing that I have found to be the biggest challenge. But I don't actually feel that not being, you know, 3 feet away from someone in a therapy room has really diminished my ability to do my job as a therapist. I can think of one patient, honestly, since March, where I said, we actually need to see you in person because I really need to touch your neck. But other than that, I haven't really found there to be, I don't feel like I'm doing different things or picking different choices in therapy because of telemedicine. I don't know, Aaron, have you felt
well,
the same?
quite honestly, most of my time in clinic is doing evaluations, and my colleagues Shirley Gerson and Teresa Lynch really do the bulk of therapy. So in the few patients that I've had for telemedicine, the biggest problem has been the sound. We have to use our proprietary system that runs through the NYU Langone app, which is based in Epic. So there are no sound options. So I have no idea how it's processing the sound, but there definitely sound gets cut off. You know, the sustained sounds often get cut off. I do work with singers. I've worked with a couple singers, and it's, you know, it's okay. It's, you know, the advantages of not having to travel for the patient. That's nice, but I definitely ultimately would prefer to be in person because of the audio quality. I tend not to do a whole lot with hands-on therapy, but I do, you know, have patients move around, and they can certainly do that in their own space. And I think it also challenges us maybe to think about how much we're talking. I know that, you know, motor learning principles, it's good not to give too many directions. And I as you can tell, I like to talk as a vocalist myself. And so it's been good for me, I think, to step back in the telemedicine, teletherapy sessions and say, okay, maybe I'll let them talk more and try to let them explore and do less teaching and more listening. So a good challenge for me.
It seems like that's been kind of a pleasant surprise. I've heard that before. There was a lot of apprehension about televoice therapy, and it seems like people are finding that actually it works pretty well. Is that a fair assessment?
It can overall. I think it's, some of it comes down to personal style. Some of it comes down to the kind of patient you have. You know, Amanda, I had someone in their car as well, and I said, let's reschedule this because this is not going to be productive with you actually driving. They were actually driving and trying.
Oh yeah, that's not, don't let them do that. Right. But you know, I think the accessibility though, because what maybe you're losing sometimes in having really great in-person audio quality, if I'm not sure, I'm like, I don't know, how'd that sound to you? How'd that feel to you? You know, it's up to them anyway. Who cares what I think? Seriously. And so,
absolutely.
but the accessibility, that they can, I'm treating people who live in South Georgia who never would have driven up to Atlanta for therapy. And now I can see them every week, and hopefully I'm providing good care. You know, I think that beats the tech problems.
All right, let's talk about the laryngology side of things. David, you had talked earlier about how some of the challenges. What do you think? What's working on telecare and what's not? Laryngology.
Well, I'll tell you, I see very few telepatients now. I was, you know, my day was full with them before, and I hated it. I just hated it. It was bad on my voice. I found it very unsatisfying as a, you know, someone who's trying to help people that I basically couldn't diagnose anything. I was like, well, you know, someone's saying that they were having, you know, throat pain and referred otalgia. I was like, okay, I can't tell you anything about that until we look. I totally agree, though. I think that it has been a real boon because we also have a pretty wide catchment area. We see patients from, you know, all over Florida, you know, over probably 200 miles away, 300 miles away. And these are people that were always lost to follow up for therapy.
Mm-hmm.
And so it has been a tremendous help that we have, especially for surgical patients who may come from, 5 hours north and then they can't get any therapy. And so being able to do that has been really huge. But as a laryngologist, as a physician, I think that other than maybe the chronic cough patients, it's been sort of a bust for me. I do tend to use it for, to check in on people, for that kind of thing, but I don't see it as really replacing much of the regular evaluation. I mean, there's a reason why for 50 years we've been arguing about why you need to visualize the larynx for someone with these symptoms, and that doesn't change in the midst of a pandemic.
But I think what you said about follow-up is true. If someone's coming to you because they just need to discuss their modified barium swallow results or something, that absolutely you can do over telemedicine. But yeah, for the new patients, for sure, you're missing something. But for a lot of those follow-up folks where you're just chatting,
I mean, I could do that with a phone call, though. I mean, that is what I've historically done, and I guess it's about, is it worth it to go through the trouble of having the 85-year-old figure out how to use Zoom, or get their grandson to help them do that, versus just making a phone call.
Well, but you can bill. I mean, you can bill for that phone call now, so that's nice.
You can.
Rhonda, how about from your perspective, what's working, what's not for telemedicine?
I think like in all other areas of medicine and society in general, what this pandemic did was identify for us areas of systemic injustice and inequity in the nation. Our infrastructure in Texas for telecommunications is really, really poor if you're outside of like the hot 6 urban centers. And so anyone who's kind of like outside of our outer suburban loop has not really been able to take advantage of these services. The number of scheduled telehealth visits that I converted to a telephone visit because that was all we could do was really high. The internet literacy is not great in large segments of our population. And interestingly, that crossed over age as well. There were plenty of folks who were in their like 20s and 30s and 40s who were not able to negotiate our particular telehealth platform. And so I think once we reopened kind of like towards normal, like our chairman, again, because of our limited physical space availabilities, assigned us like days of telehealth. And I think part of my problem was that setting aside a day of telehealth did not work. I need it to be kind of sporadic and allowed so that the patients can access it when they need to, like the first appointment of each half session or something like that. But it's probably going to sunset in my practice, other than me making phone calls like David, because we just really can't get the demand and the supply to line up. And it has a lot to do with the IT infrastructure here outside of Austin, San Antonio, Houston, Dallas, and like 2 other places. And it's pretty disappointing.
The infrastructure totally matters. And we at USC, like at NYU, we had established the infrastructure about a year prior to the onset of the pandemic. So we were kind of well positioned. So we've had less of those sort of issues. I got to say, I've really found telemedicine to be extremely helpful myself, just as a little counterbalance for, one, we had the infrastructure in place on our end, and it seems to work well with mobile, with phones, reasonably well. It needs to be improved. And we have plenty of issues, but largely doing okay. Accessibility totally matters for new patients who might not otherwise want to come in. I found that to be a real boon. For follow-ups and conversations, super useful. And one thing I have found, the telephone visits just don't have the same personal connection. So I do find that when I have a new patient on telecare and I'm in a good environment where I'm not late for running from procedures and trying to squeeze something in at the wrong time, when I have a telecare block, I am on time, I've got good tech for it on my end, which helps on the patient side of things. And I find you can really get a good personal connection. And I do find that having some dedicated time allows me to not just want to get to the scope, can kind of dig into the problem a good bit. And then the upside is we can get our patients typically in schedule, obviously next day if we need to, but typically within a couple weeks. but the no-show rate has gone down to effectively 0, which has been super helpful just from, especially when we've got some limited resources on the room side. So I found it to be super beneficial for airway stenosis patients to be able to monitor them just with peak flow meters and conversations. I'm sure the bean counters won't like the routine airway endoscopies that we were kind of doing every sort of 3 months, and now we're foregoing for kind of remote monitoring and conversations. But I do think there's value there, and I think it's going to be here with us to stay in some way, shape, or form, because I think patients are going to demand it.
So, Mike, I'm going to push back a little bit on that just in the interest of sort of keeping this interesting. How do you have time to do these telepractice visits? Like, do you take time away from your in-person visits so that you have a set-aside block of time so that you can have a face-to-face conversation with the patient about your CT results? Because for me, I have too much, between surgery and clinic, I have to fit in those phone calls kind of in the little 5 minutes in between. How do you do that without subtracting from your overall productivity and ability to see patients?
So we're limited a little bit by clinic availability for us, and so I've got telecare blocks because like in Ronda's situation, we've got sort of less rooms available for in-person visits. So I do have blocks for it, and I think that that does help. There's actually a paper that's going to be presented at the Fall Voice meeting about empiric diagnosis versus diagnosis on the in-person visit. I don't know the results of that, but we did a study on all our new patients in the first 2.5 months of the pandemic, what our empiric diagnosis was and compared it to the in-person diagnosis. And we were right about 80% of the time, which is, great, but it's at 20%, of course. So it doesn't obviate the in-person exam at all. But for me, it was at least good to know that we can actually be pretty well on mark on our assessment for those situations where we need to start some empiric therapy, thinking about a second surge in the fall.
I think this is part of, basically just a funny answer for David. You pay for that from your soul, not from your productivity. Unfortunately, it isn't really, it is in those margins and in those in-between spaces, unfortunately. And that's what American medicine runs on, is our goodwill and our sacrifice. And I think some of that is going to have to be clawed back, because the amount of burnout that is happening among healthcare providers of any denomination over what we've been asked to do in the midst of what we're being asked to do it in, I think we've reached kind of like our breaking point.
How are we navigating the interprofessional elements of actually, Yael, chime in. Give us a question here.
There was a lot of questions regarding PPE and the level of PPE for each procedure for those of you that do some in-person speech therapy. So for AGP, non-AGP, kind of talk about what type of PPE do you use?
This is a good practical question. So I'll just start with this. So we are wearing regular masks all day long. And then when we're going in to do an aerosol generating procedure or a possibly aerosol generating procedure, which we do include laryngoscopy, if the patient gets into a big giant coughing fit, I mean, it's hard to state that there's not going to be aerosols generated for that. So we're in regular masks and then of course gloves in the patient encounter. And then when we do our procedures, I'll apply drip with a little syringe of our topical mix in the nose for a flexible exam. We'll let that sit and we'll go out and we'll don our PPE. And so then we put an N95 under our regular mask, a face shield, and we are using gowns and the standard double glove. And then we go in and then do the procedure. And if there's no situation in terms that we believe on our clinical discretion, if we don't think there was an aerosol generating event there, then we're just wiping the room down, all the surfaces are getting wiped down, and then we don't have a downtime. For our aerosol generating procedures, we do have downtime built in based on our circulation time. But what are people? Are other people just wearing N95 all day? How's it going, Amanda? How's it going? What are you guys?
No, same thing. So paper procedural mask all day long, but we're also wearing eye shields for all patient encounters. So most of us are wearing these like goggly things. And then for exactly what you're doing. So for a scope and also for a voice evaluation, or swallow evaluation, it's N95, mask on top of it, Ronda's eye shield. Yep, that's the ones we all have. And then gown and gloves.
David?
So yeah, I'm wearing an N95 all day. When I'm scoping a patient or examining them, I wear sort of that paper mask with the face shield kind of going up like that, the splash shield. But if I'm just talking with someone, I'll only wear the N95. I don't wear gowns. I don't wear bonnets or anything, like I said. We have had to change. We don't use any of our aerosol generating sprays, so I can't use sprays in the nose or for laryngeal anesthesia. So we're using kind of, it's like something you screw on. It's like a Lure Lock adapter. It has this little cone on it to kind of drip. It's definitely so inferior to our usual spray for the nose. I've definitely noticed patients being more uncomfortable with endoscopy. And then for laryngeal anesthesia, we're just injecting it through the cricothyroid membrane rather than having them inhale it. And that seems to work very well.
Yeah. Ronda?
Wow. I feel like I'm going to be the outlier here. I force my trainees to wear their N95s. I'm not always wearing it. We also have a head, in addition to these trendy goggles, we also have a head mounted face shield, and our staff are required to wear them at all times when interacting with any patient. We briefly had anybody exposed to those masks that, or got sent those masks that had the little perforation for the scope to go through them.
Yes.
I hope this doesn't offend anybody, but like I couldn't get the scopes to go through. And by the time you made the hole big enough for the scope to go through it, like it wasn't doing anything anyway. So when I'm scoping someone through the nose, I'm making old school cottonoids, and I'm really glad I trained with super old doctors. I make my own cottonoid with a single cotton ball split in half, and then we pour the Lido and the Oxy into a little medicine cup, and I slide those in with a bayonet, and I have a very low cough sneeze rate of maybe like 2%. And I find that the prolonged contact from the cotton being in there impregnated with the liquid is working super. It's actually for me better than it was when we were doing spray. Because I think a lot of the medical assistants didn't spray effectively, and it was mostly medical assistants spraying in our practice. And then I just, I'm looking for my mask. I'm so sorry. I had it. Here we go. So like I do the encounter, I have on my face my mask, and I have them give me the history like this, and then I do this to put in there. I just take back the nose to do the cottonoids, and then I'll do a quick, and then this goes right back up and then I do the endoscopy with the mask here also, because I have just found that I get a lot more coughing than I get sneezing during a laryngoscopy. And so like I feel a lot more protected in that regard. And a lot of times I'll also just turn up the old room air exchanger from 2 to 3. And that creates for me a bit more of a safe environment.
Aaron, what's happening in NYU?
I think I described earlier that I'm pretty much, head to toe. I've got the N95 on whenever I'm in a patient room. Our institution requires all patient-facing staff to wear the face shield. So I've got my own, mounted one, the head big welder thing on all the time with the bonnet and the gown and the gloves. Get to wear scrubs now, which is nice. So I haven't worn khakis in 6 months. So it's kind of nice.
No hard pants.
Yeah.
That just takes fashion out of the clinic. Pleasant not to have to think about that.
And then the patients, Ronda, like you were describing, we have the patients all masked, that's required. And then for scoping, we just have them bring it down below the nose as you described. And although some patients just seem to have a hard time keeping their mask on their nose when they're talking. I don't know where they're getting these masks, but they just keep they slide down the entire history and they're just constantly pulling up.
We're often wearing them upside down too, or inside out, or both.
Well, so there are the ones that are fashioned. It looks like it has a beak for your nose, but unless you have the exact right nose for that mask, if you have a little bit more of a lower profile, all that does is fall and slide down. And so I'm telling those patients actually that they should wear that mask upside down, because then that hook goes under their chin and the flat part stays nicely on their face, especially for people who just don't have a high projected nasal bridge. It's working a lot better because and then the very emotive, very expressive face it's just going to bring it down. I have a resident like that. His mask is never on because he is just an emotive talker.
Yeah, the upside down mask is a good trick. A lot of them work better upside down. Actually, they'll stay on better.
Yael, I got a question for us. We're getting to the end of the hour, so we'll see what we got. Audio.
Yeah, can you hear me?
Yes.
Yeah. There's two questions. A very good one was about trainees. So how do you do to manage resident education, fellowship education? And then if we have time, we'll talk about how all the PPE and all the protocols are reducing the amount of patients you see for the day. So we can start maybe on the education part and what did you do with your trainees?
Yeah, trainees. David, what's happening in your clinics?
So at the beginning, I was trying to limit that, definitely. I mean, because pre-pandemic, we would typically have, a resident and, a visiting student and a medical student, and we cut way back on that. We've basically reintroduced now having residents in clinic, sort of doing their full, taking history and doing endoscopy, as long as they're wearing appropriate PPE.
Amanda?
Same. Yep, residents, fellows are back. Our speech pathology clinical fellow is just starting this week, so I think that'll be interesting that we're doing so much therapy over telemedicine. So trying to train and teach and have her participate will just be a learning curve for all of us.
Aaron?
Yep, we're a similar situation. We've gone back as long as they're wearing PPE. They're welcome to observe and take part in clinic. The one thing that is a challenge is because we're doing all therapy through telemedicine, the speech pathology students, usually we have a student intern coming for an outplacement, and we have not been able to figure out how to do that because our system is closed. It's a point-to-point communication, so they can't really observe or be a part of unless they're part of the medical system, which they aren't. So that's been one limitation.
Ronda?
We are very much like David. They are back integrated, but sadly, my clinical days are aligned with head and neck, heavy OR days, and so it's back to me being by myself anyway.
Yeah, that's pretty similar here. So we have PPE. We have no problem with PPE. So our trainees are welcome in our clinic. We've actually been limited more by crowding in the clinic and social distancing, and so our fellows, Yael, hello, are in clinic with us. Our residents, as needed for certain procedures that would be valuable to them, but similar to Ronda, we didn't have a lot of resident presence in our clinics before, and so and then of course we don't have medical students, and their presence in the clinic is significantly reduced. Again, more just related to crowding in the clinic because we've got fairly tight space. And that's bringing us to about 2 minutes to 6. Yael, what was the second question?
Yeah, the last question was about how your clinical load is reduced and how do you see it changing in the future?
Yeah, this is a very real. We're certainly, is anybody seeing more patients than they were before? No. So,
well, yes, kind of, because I think people are less likely to cancel or no-show on their voice therapy.
Yes,
so I think we're actually busier.
Lauren Timmons-Sund and Eugenia Castro, our two speech pathologists, they're seeing more patients. Carla Odell and I were about neutral if you count the tele-patients, but our in-person visits are down. And at the end of the day, that is based on how the remuneration works in American healthcare, which is so volume and procedure driven. I mean, that's affecting us. very.
Yeah, I mean, I definitely am seeing a little bit of a downtick, as I mentioned before. And there's certain subsets, like for example, I haven't done a thyroplasty in a few months because nobody wants to go to the OR for that. It's such a sort of, I think patients view it as elective and they want to wait until this is over. But it's being made up for on the other end by, getting slammed with trachs, so I'm having to go do that instead. So yeah, in the end, it ends up being pretty neutral.
I am, oh,
Go ahead, Ronda.
I am, I guess Texas is just a little bit weird. My patients are calling, like, they spent the entire pandemic calling, asking when we were going to be open again for surgery. Like they're afraid of almost nothing. And we are, booking surgeries as fast as the patients are available to come, and the hospital will physically let us. And because of their COVID testing protocols, sometimes we're having trouble getting them in, just in the time. But yeah, that's what's going on here.
Yeah, we definitely took a while to ramp up to our pre-COVID volume. We're at the pre-COVID volume now. The thing that's really changed is the makeup of our patients, and particularly performers. Being in New York, we saw a lot of folks that were performers, and obviously with performing venues all being shut down, people aren't working. So one, they aren't using their voice as much and they're not getting as many problems, but two, they don't have money or they may be out of the city altogether. So that's one of the biggest changes, sort of my clinical day. I'm used to seeing quite a few singers and now maybe one or two throughout the day.
Well, I think it's about time to wrap up. We certainly seem to be in this for the long haul. We could talk about this for hours. We love talking about this. We could get into lots of little nuances of each little piece, and certainly wish we had time to, and of course energy, it's getting late, to do that. But hopefully this has offered some perspective on what's happening in select places around the US and the current stage of where we are, and fingers crossed that we will be heading into better and not worse as we head into the fall.
Yeah.
Stay well, folks. Enjoy having your masks off. You're on Zoom in your own home. Otherwise, come on.
Thanks.
Be safe, everyone.
Take care. Bye,
Bye.
folks.
Thanks, everybody.